but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Very good evening to our virtual audience and Pioneer Fan Club. My name is Gaurisan Thevendran, consultant orthopedic surgeon from Singapore, and I'm SICOT's Education Academy Chair. I welcome all of you to today's webinar. Today's is the 5th limb reconstruction webinar and the 67th in our series of Pioneer webinars. To date, we've had up to 40,000 live viewers on the Pioneer platform and over 60,000 on demand. And I thank you all for your ongoing support, and to all the panelists and faculty who have given their time and effort to be part of this pioneering journey from June 2020. Now, today's webinar promises to be no less exciting. We have panelists from across the UK, Europe, Egypt, and the US. And the topic in discussion is Fibular Hemimelia. Moderating the session today, we have the Chief of Pediatric Orthopaedics from King Hussein Medical Center in Amman, Jordan, FIRAS SULEIMAN, alongside SABHARWAL, who is the Senior Consultant Pediatric Surgeon Chief of Orthopedics at UCSF in California, US. Please engage interactively in this discussion. Questions will be fielded to the panelists during the webinar and after. And we would very much like your feedback at the end of the webinar so we can make this entire experience even more useful. And on that note, I hand you over to our moderators. Thank you.
Thank you, Gal. It's a pleasure and an honor to moderate this with my dear colleague, FIRAS SULEIMAN from Jordan. And as you said, this is going to be a very lively discussion and presentations from leaders in the field from across the globe. The format's going to be about 8-minute talks for the most part, and then hopefully we'll have time for discussion and questions towards the end. And I encourage all the participants to use the chat box to sort of put in your questions and comments, and hopefully we'll address these towards the end. So without further ado, I'd like to invite our first speaker, Dr. James Fernandes. Dr. Fernandes is a consultant pediatric orthopedic surgeon at Sheffield Children's Hospital in the UK. He's the lead for the pediatric limb reconstruction unit at Sheffield and the past president of the British Limb Reconstruction Society. So, James, you can take it from here, please.
Can you all see? Yeah.
Yes.
SANJEEV, thank you very much for the introduction. And it's a great honor to be here as part of the faculty. I've got no disclosures to declare. For all of you, I'm sure know this little details that fibular hemimelia is the commonest long bone deficiency syndrome. Possible incidence is 7 in 20 per million. Etiology is still unknown and probably an embryonic insult at 6 to 8 weeks. It's a spectrum of disorder, varying degrees of deficiency, short tibiofibular segment, short femoral segment, hyperplastic lateral femoral condyle, problems with knee ligaments or laxity, ankle and foot anomalies, including coalition and absent lateral raise of foot. There are quite a few classification systems, and there are 5. 1952, Coventry and Johnson. Most of it was just to describe what the tibiofibular segments looked like. It did not help much, actually, in treatment pathways. Probably Ackerman and Kalamti classification is the most commonly used, but it's again descriptive of only the segments of the leg rather than any other associations of the spectrum of condition. Stanetsky in 2003 published in JPO, where gradually the understanding became better. They added 3 to 4 parts where they included regarding presence or absence of the fibula or hyperplasia. They talked about the ankle joint in terms of its angle, whether it's horizontal, valgus, or ball and socket, whether there was a tarsal coalition, and number of foot trays. In 1998, John Birch actually originally classified this, which I like very much, and later they modified it in 2014 with Reggie Hamdy when they started to apply it for more reconstructive strategy. And here, basically, the classification is based on the importance of the foot, number of rays, percentage of LLD, and also they included the upper extremity as well as bilateral affection. So based on this, they subclassified, as you can see on the diagram on the right. And this was the first classification to guide treatment pathway. Paley subsequently published his classification predominantly based on the ankle joint, and this brought in a new kind of concept for reconstructive options rather than a choice of ablative reconstruction. I'm not going to go through the details of it. As you can see, a stable ankle, a dynamic valgus, a fixed equinovalgus. Equinovarus is very rare. I've seen only 2 or 3 in my career. But when you put them all together, if you see this clinical example, if you look at the classifications, they fall into all different types of groups depending on how you have used it. Therefore, if you see the Stanetsky, it goes into including the ankle and the foot. Similarly, the Birch classification and Paley's is based predominantly on the ankle joint. So what are the management goals? I think it should be stable joints with reasonable range of motion, a normal mechanical axis or alignment, almost equal leg lengths, with the least amount of psychological trauma, educational progress, and a functional foot in plantigrade position at the end of treatment or skeletal maturity. If you look at this example of mine with a 3-ray foot and standing on the podoscope, you can see it's a good foot. And this is where the classification comes very helpful, both of Stanetsky and John Birch, and the concept of the functional foot and the non-functional foot. Therefore, the options could be a reconstructive strategy with multiple operations, an ablative strategy with SIMEs or similar amputations with optimized prosthetic reconstruction. It's quite a dilemma for parents. Informed decisions based on realistic expectations is very important. And I work in India as well, and different choices could be in different cultures and healthcare deliveries. So all this come into play depending on where you practice. The 2 strategies are either you do lengthening reconstruction or ablative. And if the shortening is more than 30% and the number of rays or the ankle is deformed, then probably your outcome is poorer. Many of the original publications, including from Texas Scottish Rite, functional outcome obviously was better in the milder group, but they also weighed against a number of procedures. Whereas when it comes to ablative procedures, I think it's simple, single operation, mostly satisfactory result, but one should think about cost of lifelong prosthetics, especially in limic countries, and healthcare costs. So in Birch's classification, the better part of it is when it comes to the non-functional foot, It was classified as any upper limb functional, then you can do an early amputation. Non-functional goes on to limb salvage. But you have upper limb defects, then of course, beware of amputation. Probably you would like this child to use their feet as their hands. There's a bit of literature for mild to moderate. There have been reasonably successful rates. Severe forms have had major complications, including from Gibbons and Bradish 96 and Katani in 1998. And a big series of 157 patients were L-SIAT, type 2 Kalamchi, 107 minor complications and 19 major complications. I think if you look at all these papers, presence of at least a 3-ray foot gives a better functional result. Cosmetic acceptance by patients, especially from Tony Herring's experience as well as from Sheffield. And we feel around 20 to 30% is reasonably safe. Anything more than 30% LLD is debatable. Now, one should remember that final outcome depends on the number of mortise lengthenings. I usually go to 4 to 5 centimeters rather than 7.5 or more each time, because definitely you'll get significant ankle stiffness and eventually they land up with ankle fusion. Irrespective of the ankle procedures, whether you do a super ankle or any other, the more number of lengthenings, probably the worse is the outcome of the ankle joint. So surgical expertise is equally important. Just to show an example of this young lady, a functional foot, 2 lengthenings and an osculus osteotomy, and another one with 4-segment affection, the final result at skeletal maturity. So coming to ablative reconstruction, I think when it comes to lemic countries, it's not acceptable. When I go to India, I still cannot get anyone to accept an amputation, though might be the ideal candidate. Whereas ablative reconstruction is one single operation followed by minor procedures, good functional activity, has to wear prosthesis lifelong. And to be very frank, in my practice, most of the patients feel that is the best acceptable way for anything more in the gray zone or severe zone. Whereas here, you've got an equina valgus, maybe in the original classification of functional foot, it is not functional, but probably with modern techniques, you could possibly reconstruct and lengthen. So just to let you know from our demographics here itself, we have had 7 sort of secondary amputations after previous reconstructive surgery, both for fibular hemimelia and another 3 in PFFD. So I think these were poor patient selection probably, and these were in the initial stages of our center developing the service. And this is just to show you pictorial timing of secondary amputations. I mean, though most of those amputations were done after I started as consultant, many of them were from preceding cohorts, as you can see. So finally, to end, I feel Birch and Paley classifications possibly helpful in treatment pathways. 3 rays or more, or a functional foot, or conversion to one. Predicted LLD of less than 30% safe. Capable MDT team and surgical expertise, which is extremely important. And I think informed decision making for anything worse than above is really vital. And ablative reconstruction, a good choice in the right settings. As far as I think, different countries have different systems, so cultural settings in your own country may dictate treatment pathways. Thank you.
Neeraj, I think you're muted.
Am I muted? You're not muted. I'm not muted here.
Oh, no, Firas is trying to say something.
I've exited, yeah?
Yeah, you're good. You're good.
Thank you.
Good, James. Thank you so much. Firas, were you going to introduce? I can't hear you. It's okay. Maybe there may be some audio issues. So I'll introduce my dear friend, Reggie Hamdy. Reggie is the chief of pediatric orthopedics at McGill and at the Shriners. And he's going to talk to us about treatment plan for fibular hemimelia from birth to skeletal maturity. Dr. Hamdy.
Thanks, Sanjeev. Do you see the screen?
Not yet, Reggie.
And
Yeah, it's good now.
is it okay now?
Yes, thank you.
Okay. So thank you, Sanjeev, for having invited me. It's a really honor here, and thank you for all my colleagues. My talk will be essentially on the planning for fibular hemimelia from birth to skeletal maturity. I have no disclosure. So the child with fibular hemimelia, what to do? If you have the first time they present, it's newborn, or whether later on or during adolescence, what really we need is a long treatment plan. And this treatment plan starts from the first visit, whether at birth or later on, and till skeletal maturity. It's a very long journey that will take many years. So we have to be very clear. We have to provide the family with a clear treatment plan. This journey starts at the first visit. And at the first visit, we all know the parents have many questions. They are desperate for answers. So during this visit, you have to take your time. It's at least half an hour or 45 minutes. Get to know the patient and the family, address that concern, and gain that confidence. There are three things that you definitely have to discuss. Number one, what is the condition? Like, what is fibular hemimelia? And I think James Fernandes alluded to this. What are the problems that need to be addressed? What are the options? And then after this, you provide them with a lifelong treatment plan, a sort of a roadmap that will go till skeletal maturity. And in many cases, you may need more than one clinic encounter. The condition has been discussed, the problems that need to be addressed, and each one of them has to be addressed in detail. So some of the children fibular hemimelia had hip dysplasia, LLD, and we are going to discuss each one, knee instability, tibial deformities, ankle deformity, as well as the parvus malalignment. So we have to explain this, and we have to define how all this will be addressed. The two options of treatment, it's simple. It's either reconstruction by preservation of the foot and multiple lengthenings, or a reconstruction by amputation and prosthetic fitting. And if you notice here, we use the word reconstruction. We don't jump usually to amputation because the whole lower limb is in fact reconstructed. Before we proceed, just I want to mention one study by John Birch, and essentially the conclusion after a follow-up, I think 2 years, is that essentially both options of treatment give very good results on the long term. So I think that would reassure the parents and the family. So what they need to know for either option is that what can they expect for the child and the coming years? How many surgeries, what the type of surgery, what type of fixator or nail that you're going to use, what is the timing of the surgery during the childhood years and the adolescence years, how to prepare that child and themselves, like what's the length of the hospital stay, post-operative physio, the time the fixator is on, and after discharge, what is the frequency of the clinic visits, possible complications, what are the activities allowed. So all these are part of the treatment plan. Most important, the treatment plan really will be successful only if you have an interdisciplinary clinic that include not only the surgeon, but that include all these people. It's a complex condition, and you need the support of all these multidisciplinary clinics when you're putting the treatment plan. So the treatment plan also, you can use supportive material. Like parents probably have never heard of vestibular hemimelia or lengthening. So you can supply them with dolls with a fixator, with certain brochure that explain what is the process. And something that really needs to be done is that you can make them meet other children who have the same condition or families who have gone through the same condition. And the very, very important something that should be available is that they should have access to a telephone line availability 24 hours, 7 times a day, at the beginning, during the treatment, and post-treatment. I cannot overemphasize the importance of intensive physiotherapy, which is a major part of the treatment plan. And we all know if there is no regular intense physio, then there is no success. I will go quickly through the two scenarios. First case is preservation of the foot, and the second case, it will be amputation. So the first one is a child who has this picture. You can classify valgus of the ankle joint. So again, these are the problems that you have to address and see with the family how you are going to address them. How to address the LLD? Roughly speaking, you calculate LLD skeletal maturity, and you know if you have a 2 centimeter at birth, this will give you about 15 at maturity. How you deal with this? It's a standard written everywhere. You will need 3 lengthening. The first one is when you cannot tolerate, the child cannot tolerate the shoe anymore. Second one around age 10 or 11. Third one at skeletal maturity. Or you can combine it with the contralateral if it is releases. You may lengthen the femur. So only for this, for the addressing the LLD, you will need 7 surgeries during the course of the year. You might need another surgery for the knee instability, the super knee, done around the age of 10 years. The ankle deformities, depending, there is a whole list of supramalleolar osteotomy. You can do the short procedure. If it is flexible or rigid, you do the super ankle. You may need also another surgery for correcting the bowing, and you may need another surgery to correct the valgus malalignment in the form of a gross clip. So if you put all this together, you see that you will need about 12 surgery to reach the end of this long journey. And you have to mention this to the parents before, plus could be also unexpected and unplanned surgery. So we continue with that child. At the very beginning and for a few years, you may not need to do anything. You simply do manipulation and casting, and then a shoe lift until the patient does not tolerate anymore. And we'll continue. The patient now reached 10 years. He has an LLD of 7, cannot tolerate anymore. Therefore, the plan is 2 lengthening. The first, the lengthening that you do, you remove the fixator after 4-5 centimeters. You got a fracture. You put elastic nail. That's surgery number 3. After that, they have the valgus malalignment. You put an 8-plate, surgery number 4. You remove the plate number 5, and then you put the final one, a last lengthening. So that's the second part, and includes 7 surgery. All this, again, you should be planned, and you should explain it to the patient. The second case, it's a foot that is by all means, it's unreconstructible. It's not a functional. So the plan that you give to the parents after discussing with them, sign is amputation at the age of 1 or 2, followed by prosthesis. Then many of these develop the valgus malalignment even after the signs, proceed with an 8-plate. You may have stump problems, and you need the regular visits to the clinic for the prosthetic fitting and adjustment. You can discuss also with them the cost of the procedure. So the take-home message, if you have a child like this and you want to avoid him to be like this, you need a detailed planning that you offer to the parents in the context of a multidisciplinary clinic. And you have all this, that will be your end result. So thank you.
Thank you, Reggie. That was great. And, you know, we have a last minute change, which really was our original schedule. And so it's my honor and privilege to have Dr. Dror Paley come and speak to us on surgical reconstruction of fibular hemimelia. As you all know, Dror is the founder and medical director of the Paley Orthopaedic and Spine Institute in West Palm Beach, Florida. And before that, he was at the Rubin Institute for Advanced Orthopedics in Baltimore, and was the past he was the past president and the founding president of the Limb Lengthening and Reconstruction Society, of North America. So, Dror, please take it away.
Thank you. Can you guys hear me okay?
Yeah.
Okay. So I'm going to talk about the super ankle procedure, particularly in the reconstruction. So, we're starting with an equina valgus problem with these feet and tibias. And what's the cause? Well, diaphyseal valgus procurvatum is part of it. And then maloriented tibial plafond is the invisible deformity because the distal part's non-ossified. Then you've got a malunited subtalar coalition. You've got, and here's a good example when it's ossified later, you can get a 3D CT showing that the talus and calcaneus are actually beside each other. They're not stacked one on top of the other. And so once we recognize this, we realize that we need to separate those. And then there's a telage, which is pulling us into valgus. There's secondary contracture of the tendon of the other bony deformities. The foot's never been out of equina valgus. So you've got all of these problems, plus you have tibial deformity, as we said, knee deformity of valgus due to the hypoplastic lateral femoral condyle, leg length discrepancy, knee ligament insufficiency, AP and rotatory, etc. And, what we've learned from the literature is the results are due to recurrent or residual foot deformities and not the leg length discrepancy. So the main thing is dealing with on this. We have a classification of this, and the key is that most involve just a leg length difference. You have the dynamic; these respond to what's called a short, and then you've got this fixed equina valgus with just ankle malorientation, subtalar malunion, or a combination of the most common, and a dislocated type. And finally, the club foot type, which is just a varus subtalar malunion. So I'm going to focus on the type 3 evolutionary wise. When we distracted these, 100% recurred, soft tissue release, 50% recurred. And when we did soft tissue release plus osteotomy, we had less than 10% recur. And that's the super ankle procedure. So here's our model, type 3C. And what we're going to aim to do is a subtalar osteotomy, a supramalleolar osteotomy with shortening, and some soft tissue work. So we start with getting rid of the onlog laterally. We then do a subtalar osteotomy. We then pin the ankle so that we can then lever the subtalar osteotomy over. We do a supramalleolar osteotomy. We displace it to shorten the leg. This allows us then to displace the subtalar osteotomy over, and then we pin that, and then shorten by the amount of overlap, and that is the super ankle procedure. This is what we end up with, and this leads to a completely aligned leg. The alternative is to do a soft tissue release, circumferential release, and realign the malunited subtalar coalition in a vertical position. There's less indication for this, and this involves a circumferential release of the ankle with enlarged resection. So circumferential release, supramalleolar, displace it, overlap, and then cut that off, pin it after you shorten it, and different kind of correction. So those are the two types of super ankle. So let's go through this incision-wise, okay? Incision is an L-shaped incision like this. Elevate the flap with the fascia that's underneath while sparing the superficial resect. So here's opening a superficial perineal nerve. Fascia is kept with the skin. Elevated. Anterior and lateral compartment exposed. Find the interosseous membrane. Resect the onlog. So there's the onlog being dissected. Interosseous membrane resected. Onlog dissected. You now, under the flexor hallucis longus, you can see the posterior tibial vessels. See them, protect them, and then resect the way to do it. After you've done that and removed the third segment, you can now go after the Achilles tendon. You do a coronal split of the Achilles tendon. lengthen it about 4 centimeters of tendon on either side. Do a capsulotomy of the ankle. This shows you how flat the talus is. Bottom line, final result of ankle motion related to how flat the talus is. Very round talus, good motion. Flat talus, no motion. So you lack an offset or recess in the front of the talus. The calcaneus is impinging on the back. You find that point where the talus and calcaneus come together. It's very obvious. You split at that point. Okay. You break the coalition. Now you go to the tibia, T-shaped periosteal dissection. Okay. Pin the ankle to prevent motion of the talus. You do not want to correct through the ball and socket. You want to correct through leverage. So you do a supramalleolar osteotomy. Okay. Parallel to the bottom of the foot with one wire and the other wire. So you subtend a plane. You cut that plane so it's parallel to the bottom of the foot. Forget all of the other landmarks. Bottom of the foot counts. Once you've done that, displace it with the periosteum. Now you've got complete laxity of all soft tissues. Lever over the calcaneus. Pin it in place. Once you've pinned it, you can osteotomize at the overlap, which is here, and go perpendicular to the proximal tibia. So you go perpendicular to the proximal tibia, resect that segment, slide back over your tibia, advance the wires that you pinned the subtalar, which are perpendicular to the plane of the foot, and then that's just showing the lateral of the same thing. Reduce it, advance the wires. This is your final position. Okay? Repair your Achilles tendon. You never lengthen the peroneus longus. Very important. Otherwise, you get a dorsal bunion. Close the flap. You can resect the transverse part of the flap. Since you've shortened, you're going to have excess skin. Closes very nicely. And that's the end of the procedure. If you want, either same time on putting wires in the foot, frame like this, pins, osteotomy in the proximal tibia for lengthening, 5 centimeter lengthening. We do this at 18 months of age or older. That's the correction. Now, this is an example. So you can see the equina valgus position. So what the foot looks like. Super ankle, external fixator, 5 centimeters lengthening. At the end of lengthening, this is what it looks like, plantigrade foot. And that's the foot at the end. 18 months. Okay, you want to count surgeries. Here's her first surgery, super ankle. This back with the Elizarov days, pre-TSF. First surgery with lengthening, 5 centimeters. Okay, age 7, she gets hemipiphthodesis with lengthening. Okay, 5 centimeters. This is her function after two lengthening. She's the best soccer player on her team. That's her running. Okay, that's her functional level. Okay, there she is. She had a type 3A. There she is kicking. She's going to kick with her non-fibular hemimelia foot. Okay, and there she is, third lengthening at age 14. And then there she is doing a 5K with her mom. She's in the orange with her sisters and mom. And there she is at 3 lengthenings, and the super ankle was incorporated to one of the lengthenings.
Come on.
So I heard someone say we should count the number of rays. Well, let's count. 1 on the right, 3 on the left. Okay, let me show you the function of this kid. Super ankle, lengthening, bilateral. This is his running. Mom sent me this video, okay, showing his entire progress. And at the end of this, you tell me if you should really use the Birch classification and amputate based on number of rays, because it doesn't make any sense. So that's a prejudice that we think number of rays determines function. There's no proof for that. No one has any proof for that. Okay. With proper orthotics, they do fine. This is the kid. I want you to see his function. So this is his surgeries, and this is his function after his surgeries. So I don't know, which side has the single ray, which side has the 3 rays? So the single ray is the right foot. Okay. And I just don't see any difference between the 3-ray foot and the 1-ray foot here. Okay. So this is him at age 8, him a second time with implantable lengthening nails.
Yeah.
Okay. This is a kid in slow motion showing how good the foot function is to type 3C. Okay. The slow motion really shows you what the foot is doing. So they don't have great push off, but they have great function. All right. And this is another patient of mine. She's finished everything. She does every sport. She's not limited. She has limited ankle motion, but not limited. So we published this, found no difference in amputation limb reconstruction group, but that's the difference. Why would you want to amputate when we can achieve the same function as essentially a normal life, normal foot? You're right. Prostheses give you a fairly normal life, but why amputate when you can go through usually 1, 2, or 3 lengthenings in a super ankle procedure, the odd 8 plate? So that's published in JBJS. Bottom line is, you got a foot deformity to the super ankle or the short, and then serial stage lengthening. So if you got foot deformity and lengthening, you combine the 2 procedures. Thank you.
Great. Thanks, Dror. Next, we have a recorded talk from Dr. Radler. Is Chris here? No. Okay. So, Sophia, if you want to play the talk, and that's on management of recurrent deformities by Dr. Radler. Dr. Radler is the associate professor at the Medical University of Vienna, and as you can see, he's the head of the pediatric orthopedic and limb reconstruction team at the Hospital Spiessing in Vienna, Austria. So, Sophia, please play.
So thank you very much. It's a pleasure for me to present on management of recurrent deformities. These are my conflict of interest. Now, in fibular hemimelia, we have recurrent deformities in multiple forms. One, of course, is Leibniz discrepancy. No need to talk about that. The other is knee valgus, knee instability, and equinal valgus deformity at the ankle joint. So many years ago, we looked at the knee in those conditions, and we looked at nearly 40 patients, 5 to 14 years, with a unilateral affection, and we measured 22 radiographic parameters on a lot of radiographs. So what we found is the real problem of the valgus deformity in the knee is the lateral epiphysis of the distal femur. So we found that this is smaller in width and in height, and we didn't really find those changes so much in the tibia, namely on the proximal tibial epiphysis. Here only the epiphyseal width was reduced. So it seems the valgus deformity comes from hypoplasia of this lateral epiphysis. And in a follow-up study, we looked at recurrence, and we looked at radiographs after surgery and in follow-up, and we looked at the change of the mechanical axis deviation. We tested against cofactors, patient age, baseline mechanical axis deviation, type of CFD and FH, the severity of the ball and socket joint on the knee, and joint stiffness, but also the absence of cruciate ligaments and resection of the fibular anlage. So what we did found is that the recurrence also comes from the distal femur, again from the growth inhibition of the lateral epiphysis. The recurrence was dependent on the severity of CFD and FH. It was dependent on the resection of the fibular anlage, so resection reduced the recurrence. And we also found that the ball and socket joint configuration at the knee plays a role in the valgus deformity of the knee. This resection of the fibular anlage has found to be a factor also in a study done by Popkov and co-workers. They compared no resection to resection of fibular anlage and found that there was a quite quick relapse in the tibial shaft in the group without resection, and no recurrence or no substantial recurrence in the group where they did resect the fibular anlage. So today we know that's a very important factor. We've been resecting the fibular anlage for many, many years now, starting from a very big lateral approach to a smaller two-step lateral approach. You can also do it from a medial approach. So as you can see on the right picture here, which is a little bit more challenging. So I think the lateral approach is the best choice for most cases. The other thing we found is that this ball and socket joint, the knee joint, of course, increases recurrence. Here the problem is it's not really a recurrence of the deformity, it's a problem of the frontal plane knee stability. And this instability that we see leads to a joint line divergence and to valgus. We know that we don't have normal ligaments in those conditions. We were able to show that many have hypoplasia of the anterior cruciate ligament or posterior or both. And there is the super knee to address this, and this is a very successful procedure that was introduced by Orthopaedic many years ago. So this is nice as an initial procedure. We can also use it like a rescue knee procedure. Like in this case, I just want to show you to see how it also can affect the valgus deformity. So this was after lengthening. This patient also had a fracture in the diathesis of the tibia at some point, and you can see the joint is not really stable. I did a ligament reconstruction, super knee procedure, and extension, osteotomy, and correction of the femur. And you can see how the knee is better in rotation. You can see that a part of the valgus deformity was corrected by stabilizing the knee in the AP plane. So that's an important point. Super knee is very powerful, and sometimes you feel super happy because you were able to stabilize a knee like this, as you can see in the video, very well in regards of the AP instability. You need to make sure that there is no extension deficit, but also in regards to rotation. But then sometimes down the road you will find there is a recurrence of the instability, and this was the problem in the case you can see here. What can be the reason? The problem is that there is no notch, and it is possible for the ligament to get like wrapped up between the condyles. So this is why Orthopaedic recommends a notchplasty to protect the intra-articular ACL for some years now, and I think this is something we need to address, not to see a recurrence of this instability after reconstruction. Equino valgus can come in different shapes and forms and can be very difficult to correct. We also see that there is some lateral hypoplasia of this epiphysis, which was shown by Joy and co-workers many years ago. And so also here we can find recurrent deformities. Usually we address the equinovalgus with the super ankle, like initially, sometimes around the age of 2 years. And you can see in this case, the problem was the subtalar joint was still nicely mobile. I checked this during surgery, so difficult to fuse it in a correct position if it's still mobile. But of course, long-term follow-up makes everything more difficult, and you can see in this case how with time you just see your usual double barrel shaped fusion between the talus and the calcaneus. So in cases like this, you need to address this problem secondarily, which is sometimes not so easy because there's also a deformity in the midfoot forefoot that you need to address doing this. What are other possible mechanisms of recurrence of the equinovalgus? It's insufficient initial correction. When we bring down this calcaneus underneath the talus, we need to be very careful not only to bend the talus within the ankle mortise, so you need to transfix the talus with K-wires during surgery while you're doing this, which can be tricky. It's small, it's soft, so this is something to take care of. The other thing is when we lengthen right afterwards, we get a lot of tension in the soft tissues. We remove the frame in these cases because they heal so quickly, sometimes only after 4 months, and then there's still tension in the soft tissue that might lead to some recurrence. The other thing is we are doing a supramalleolar osteotomy at a very young age, and we might see some recurrence through remodeling from this. So in summary, I think this recurrence can be quite frustrating for parents and for surgeons, also quite humbling when you look at your long-term results sometimes. There are biological factors that lead to recurrence, and there are iatrogenic factors. We need to be sure that with knowing what we know and with trying what we're doing to limit those iatrogenic factors that lead to recurrence. Thank you.
All right. That was great. Next, I'd like to invite Shawn Standard. Dr. Standard is the head of pediatric orthopedics at the International Center for Limb Lengthening in Baltimore, and is part of the Rubin Institute of Advanced Orthopedics in Baltimore. So, Shawn, thank you so much.
Great, thank you. Let me get my talk up and going. So I'm Shawn Standard from Baltimore, along with Dr. John Herzenberg and Phil McClure. And I hope, can everyone see that now?
Yeah.
Great. So I've been asked to give a talk on management of fibular hemimelia associated with congenital femoral deficiency. So these are my disclosures. So how to manage fib hemi with CFD. First, we talk about terminology and define the relationship. You know, PFFD, CFD, congenital short femur, even fibular hemimelia, they all fall under the umbrella of post-axial hypoplasia of the lower extremity. And so that means that every CFD is going to have a fibular hemimelia, and every fibular hemimelia is going to have a CFD in some shape or fashion. So they go hand in hand, and you have to consider this in kind of this talks a variation on the theme of Dr. Hamdy with life plan management and how to approach these different deformities. And so when you look at the problems that we're dealing with in fibular hemimelia, the absent rays, the ankle and hindfoot deformity, the contracted tissues, the tibial deformity, and on the femoral side, you're looking at the coxavera and acetabular dysplasia, the hip deformities, the knee instability or knee contracture, femoral shortening, external femoral torsion, and how do you address this? How do you approach it? So when you have a patient like this who presents especially with multiple and complex segment and deficiency, you need to first assess the severity of the deformity. And that means looking at the joint integrity, the hip, the knee, the ankle. Are they there? Are they functional? Look at the leg length discrepancy, current and predicted. Not so much as percentages, but, you know, we can talk about the different severities. And as Dror had mentioned, it's about the joint function at the end. The lengthening does play a part as how many surgeries that you have to have. With that information, you then choose two pathways, lengthening reconstruction or prosthetic reconstruction. Then you create a life plan, kind of prioritize which goes first, what are the lengthenings, what's the time, and so on and so forth. If you look at these three examples, we can look at the severity in both the femoral segment and the tibial segment. If you look in the femoral segment, you have to ask yourself, is there a deformity? Does it need a super hip? Does it need a soft tissue release? Is the knee contracted? Is it unstable? Does it need a super knee? If you look at the first patient, this is a mild congenital shortening, congenital femoral deficiency. You can observe this and concentrate, you know, on the lower segment. This child has a more severe proximal femoral deformity and requires a super hip. The third patient has a severe absence of the proximal femur, and this patient is going to fall under a rotationplasty or prosthetic reconstruction. If we look at it from a tibial segment, if you look at the first patient, again, is there a deformity? There's a fixed equinal valgus. There's going to be a contracted onlog. What do we need to do? This patient needs a super ankle. If you look at the second patient, they have a flexible foot, but a distal tibial valgus. Well, how can you address that? I call this a mini super ankle, and I'll explain that later. The rotationplasty, the ankle is going to be the knee, and you have to stabilize that. So it also requires some ankle work at the time of the rotation plasty. And again, a mini super ankle plus or minus a subtalar orthodesis, depending on the mobility. Then you look at the leg length discrepancy. You can break it down into less than 5 minimal, 5 to 10 mild, and moderate, severe, and very severe. And so looking at this patient, different example, this patient has a 16 centimeter predicted leg length discrepancy. That's going to fall into the moderate category. If you look at the next patient, it's a 35. That's very severe. Then you take these two patients, and again, you assess their joint integrity and combine that with a leg length difference, and you pick your pathway. The first patient has a reconstructible ankle, good joint integrity, good ankle, good hip, maybe a little dysplasia. These are reconstructible. This patient can go down the lengthening reconstruction pathway. The second patient, obviously absence of the femur, severe discrepancy. This needs to go down the prosthetic reconstruction pathway. So once you have your pathway, we got to create the life plan and organize and prioritize the treatments. So this young person comes, you first, again, assess the joint integrity, leg length discrepancy. So the viability of the joints, he has a reconstructible ankle. It's got a 3-ray or 4-ray foot. I agree, you shouldn't count toes. You got to look at the function of the ankle. The ankle is reconstructible. The hip, the knee are good. So we're going to choose possibly the reconstructive pathway, but we need to look at the leg length discrepancy. 4.5 initially, 18.7 predicted. That puts them into the moderate to severe. So how do you roll with this? You take that leg length, predicted leg length discrepancy, and you map it out over the years. And then you can pick and choose the timing. The typical times for surgeries, at least in my hands, the first 2 years, 1 to 2 years, you're doing the joint reconstructions. You can gain 1 to 2 centimeters. The super ankle happens before the super hip. I do super ankles between 12 and 18 months. The super hips, 18 to 24, up to 36 months. And then the lengthening timeframes, it seems to be 3 to 4 years for first lengthening, 8 to 12 years, second, 14 to 16. And you have to assess how much leg length discrepancy you have. Is it worth it? You have to look at the psychosocial aspects of the child. Certain ages are not very amenable to lengthening, and you consider all the other factors. So you take this little fella and you say, okay, what do we have? Well, he needs a super ankle at age 12 to 18 months. This example of the classic super ankle is what I still perform. 3 years tibial lengthening. It's important to understand that the first super ankle is very mild lengthening, a very short frame time to preserve ankle motion. Then 8 to 10 years, this person's going to have a femoral internal lengthening, probably extramedullary. And then the final will be an internal tibial lengthening at 15 to 16 years. There are several surgeries, but they're spread out over the growing years, and the child can have a functional, happy life. But you have to plan this, and as been previously mentioned, you really have to explain this to the family. So what is the super ankle? Again, it's a whole list of different components. We all do it a little bit differently. We've seen some different variations. So the super ankle, the classic, is written up by Dr. John Herzenberg in Dr. SABHARWAL's book. Highly recommend that. What is the mini super ankle? And this is, probably opposed to closing wedge. I do opening wedge. So it's a simple lateral approach, a fibular window if you have a fibula, supramolar osteotomy, really no soft tissue releases, pin stabilization, and casting. And that's really all there is to it. I believe even in these dynamic, very mild deformities, if you correct these at an intervention like with a super hip or a super knee, the ankle grows and develops in a much normal fashion. So what are the management principles in managing fib-hemi with CFD? Well, the joint reconstruction, you have to ask yourself, can you do them simultaneously or do you do them sequentially? If a super ankle and a super hip are needed, I do them sequentially, super ankle first and super hip. If you time them just right, you can take off the frame and do the super hip and then go into a cast. A super hip with a mini super ankle can be done simultaneously. Same with super hip and super knee if it's needed. And then you look at your lengthening. How do you approach that? Well, you're lengthening the most affected segment. And so some of the lengthenings, you can look at a small femoral deformity with a significant tibial small femoral shortening with a significant tibial shortening. And if the patient's 8, you can actually over-lengthen the femur first and do that internally, and you can avoid an X-fix, and then you can catch up on the tibia internally later on. You can do sometimes femur and tibia together. So the one principle is do as much as possible. You don't want to push the patient over the edge, but you don't want to whittle on these children. You can see this kind of crazy case where we did a lengthening, a deformity correction, and a tibial lengthening. But it is complex, and you have to have the appropriate team. So if you look at the first case, I'll run through these real quick. This is a 14-month-old femoral shortening, tibial shortening, mild acetabular dysplasia, good joints, mild to moderate leg length discrepancy, I would call that mild, and spread over both femur and tibia. The life plan will be a super ankle now, femoral lengthening later, tibial lengthening versus epiphysedesis at the end. Here's the classic super ankle. Final result with excellent alignment, recurrence with a supination of the foot and valgus deformity, easily corrected with hemiepiphysedesis and tibial transfer. Later on, 4 years, the knee is becoming a little bit more unstable, recurrent valgus, hemiepiphysedesis, super knee, stabilized. Then at age 10, extramedullary lengthening with excellent results and equalization. The next stage will be a final lengthening or epiphysedesis. If you look at this child, mild fibular hemimelia, more severe congenital femoral deficiency. So this child is going to require 18 centimeters of lengthening. So this will be a super hip with a mini super ankle initially, femoral lengthening over the growing years. Initial super hip is performed. Again, epiphysedesis had a significant valgus. The mini super ankle, again, the fibular window, simple opening wedge osteotomy, very quick 30-minute, 20-minute procedure. The ankle now demonstrates excellent motion. It's stable. The hip is now healed. The child is now ready for her first lengthening. She undergoes an external fixation lengthening, post-lengthening, standing at 5 years with stable hip, knee, and ankle, waiting for her next lengthening at age 8 to 10. How about this case with the obvious severe femoral deficiency? If you look at this case, there is a flexible foot and ankle, but you have to make this into a knee. So rotation plasty with a mini super ankle and a subtalar joint orthodesis. This provides for a nice stable limb. This is at 6 weeks. Once the cast is removed, the pins will be removed. The one thing is you're pinning this child in plantar flexion because that's knee extension. And this is the child now 4 years later, walking in his new prosthesis. The prosthesis is a little bit long. He's got a circumduct, but he's doing great. Very active young man. Final case, this is another significant fibular hemimelia with mild to moderate congenital femoral deficiency. There's some acetabular dysplasia, but no proximal femoral deformity. 16 centimeters needed. This is going to be a lengthening reconstruction, super ankle now, Dega osteotomy at the frame removal. So if you time this just right, this is my little doodles when I explain to the family, here's a classic super ankle. It's now well aligned, well healed. The foot and ankle look very good. And at the time of frame removal, you can note that Dega is done and the child goes into a cast after the super ankle. So I just incorporate a hip spica cast, get everything done in one sequence. The patient is now 3 years old, ready for her first ankle lengthening. So the learning points when you approach fib hemi with CFD, they're always together. They go hand in hand. So you have to incorporate both into your plan. Assess the joint severity, which needs to be addressed. Maybe both need to be addressed. What's the current and predicted leg length discrepancy? Choose your treatment pathway and then construct a life plan to prioritize the treatment. Thank you.
Great. That was awesome. Thanks, Shawn. Next, I'd like to invite Dr. Hosny. Dr. Hosny is going to talk about amputation versus reconstruction. He's the head of orthopedic surgery at the Benha University Hospital in Egypt and the past president of the Egyptian Orthopaedic Association and the president of International Assami and Bone Reconstruction Society. I think this may be a recorded talk.
So amputation or reconstruction? I'm going to start with the conclusion. I think this is the wrong question. So even if you have the wrong question, perhaps we need the right answer. The right answer is from the start. the absence of uniform protocols, like this systematic review. We don't have a uniform protocol to answer this question. People, they always ask this question, and they describe amputation as historical, but reconstruction, they talk about new classification, mostly diagrammatic, not real-based, not based on patients. They talk about recent operations with excellent surgical exercises, but no data. Advanced techniques, non-evidence-based medicine. I think if you talk about the results, you have to talk about the real patients, the personal experience, surgical operations, the pathologies, like in this paper. Why, when we talk about anything else, we talk about the surgical load? If you want to present your experience with total knee replacement, you have to speak about your surgical load. People think that if you have surgical load less than 70 cases per year, you are going to have less results, far less than other people. But if you talk about congenital deformities, we talk about diagrams, animations, and we don't talk about the surgical loads. We don't talk about the long-term follow-up. Again, the indications of amputation. Some people think straightforward, the basics of treatment. If you have a non-functional foot, you have to do an amputation. If you have less than 3 rays, but look to this patient, 1 ray on both sides and deformed 1 ray. Look, is it typical for amputation? Look the way the patient walks at age 20 or 19. She can even run with 1 toe, deformed toe. Look. She has regular shoes. She can walk. She can run. Is it non-functional foot? Because it's less than 3 rays? Who said so? Age of presentation. People talk about the protocols at birth. But if you have this presentation at the age 38, this was the first presentation of this patient. What are you going to do? Reconstruction of fibular hemimelia. You had to think about, first thing, amputation is not an option in our area. Age at presentation, 17, 19, 2, associated conditions, previous operations, 1 stage, unimodal, multimodal, many stages. And this is an example, 19 years old male with 2 previous operations. Look at this patient. Lengthening, just lengthening. About 16 centimeter lengthening. People claim that you have to do it only 20% because you are going to have stiff knee. But look to the knee immediately after removal of the frame. This is immediately after removal. Look to the shape of the immediately after removal. Again, is it multimodal in this patient with fibular hemimelia presenting at age 8? We do physial distraction, another osteotomy to correct the deformity, and foot frame. Neglected ankle cases, soft tissue release, and putting the frame during removal of foot wires. Ankle reconstruction, fibular lengthening, about 10 centimeters for ankle reconstruction. Multiple stage, multimodal, look this bilateral fibular hemimelia and congenital short femur. First distraction, then trying to reduce the knee, ended up with the subluxed dislocated knee, correction of the deformity, guided growth on the other side, fibular hemimelia. Again, ended up with this dislocated knee. Then with lengthening and guided growth, we changed the slope to reduce the knee. And look to the follow-up. 14 years follow-up. This is after 14 years. In conclusion, if you talk about reconstruction, which type of reconstruction, which type of patients, number of patients you are doing, age of presentation, at presentation, the diagrammatic classifications, why each one wants to put his own classification, I don't understand. Based on either diagrams or small number of patients. We have many excellent operations, good surgical exercise, excellent surgical exercise, without supporting data, without follow-up. Single stage or many stages, unimodal or multimodal treatment. How would you group all those patients together? What's the follow-up period? Again, in conclusion, is it amputation versus reconstruction? In our area, there is no amputation. We cannot consider amputation. You have to think about your surgical load. If you do 2 operations per year, how would you report the results? I don't understand. The papers comes with 30 cases along 15 years from 5 centers. Okay. The family decision. Here it's a family decision rather than thinking about the functional results. Think, is it marketing or science? Are you describing excellent results or just marketing? Good results. Sometimes we report good results because there is no other options. You cannot compare it with other options. Thank you.
Great. Thanks for a very thoughtful and provocative talk, Dr. Hosny. And last but not the least, it's my pleasure to introduce my dear friend, Dr. John Birch. Dr. Birch is a professor emeritus at the University of Texas Southwestern in Dallas, and the past president of Limb Lengthening and Reconstruction Society of North America. And he's going to talk to us about final thoughts and lessons learned on fibular hemimelia. Very befitting. Thanks, John.
With some additional friends. Thank you, SANJEEV. I appreciate the opportunity that SANJEEV and FIRAS have given me to speak. I do have a couple of disclosures. The first, as I look at this photograph, is to recognize that I'm as old as dirt. And when I was young, I was often in need of a haircut. The most important part, though, is that my dear friends and colleagues, Mike Samchikoff and David Ross at Scottish Rite, developed a form of external circular fixator, and the hospital receives royalties which distributed for that. The other disclosure that is important is that I spent almost all of my career at Texas Scottish Rite Hospital for Children. And the rules for being accepted for a patient there was to be under the age of 18, a resident of the state of Texas, an orthopedic condition that we treated, and there was no charge for any aspect of the care that was provided. In other words, this was not in any way, shape, or form a reflection of the real world. What I should really title this talk, because this is going to be the theme, is change. The past is a foreign country. They do things differently there. A tribute to Leslie Poole's Hartley and the Go-Between. Well, just as assuredly, the future is a foreign country as well. And they, meaning you, all the younger people that still have a portion of your career in front of you, will do things differently in the future. And you must be prepared for the inevitability of that change. I have long been fascinated by the morphological features of congenital fibular deficiency. And I can remember as a pediatric orthopedic fellow sitting in the library at Scottish Rite and reading this article for the first time back in 1981 on the natural history and management of congenital short tibia with displays in absence of the fibula, lead author George Lloyd Roberts. But I probably changed my thoughts about this condition more than any other in my career. In 1986, my chief, Tony Herring, reported on the results of SIME amputation in children who had been performed for a variety of reasons, and concluded that a SIME amputation in a young patient was compatible with athletic and psychological function approaching that of a non-handicapped child of the same age. Enthusiastic about the developments that I had witnessed in Lecco in 1988, thanks to my friends Maurizio Catania and Roberto Cattaneo, I sought to prove that this conclusion did not hold true in young adulthood. So we contacted the adult subset of Herring's population that were treated by amputation for congenital fibular deficiency. All 13 patients in that subset were interviewed by phone and 10 were examined personally. My null hypothesis was that when these patients left the protective, nurturing, free environment of Scottish Rite, their function would deteriorate, access to prostheses would be difficult, and the patients would demonstrate some psychological disturbance. And we published those results in 1999, and basically, I was wrong. All patients had a functioning prosthesis, and they were overall a well-adjusted, content, and functional group. But of course, as you've already heard, the controversy continues to rage, particularly with new stage reconstruction strategies championed over amputation. So we sought to try to shed some light on this in a paper that's been alluded to a couple of times. With my colleagues, Dror Paley and John Herzenberg at the Rubin Institute, we tried to do a two-center comparison of psychological adjustment, quality of life, patient satisfaction, and physical function treated by SIME amputation or stage reconstruction for severe fibular deficiency. I have a confession. My null hypothesis shared by my Scottish Rite colleagues was that the SIME amputation population, 20 patients from Scottish Rite, were going to beat the stage deformity reconstruction patients, 22 from the Rubin Institute, with a stick with respect to function and satisfaction. I was wrong yet again. As you've already heard, their psychosocial function, health-related quality of life scores were comparable between the groups and within normal limits. The instrumented gait analysis at self-selected walking speed and tied 50-yard dashes were comparable and within normal limits for both groups. The limb salvage reconstruction group was less ethnically diverse, had more females than males, which is the reverse of the norm, and the parents more affluent and more highly educated. All patients and all parents reported satisfaction with the treatment selected and activity level. All of them would select the same treatment again. The patients with amputation reported greater satisfaction with the appearance of their limb, but gender and economic differences between the groups could account for that particular finding. It is important to remember that the amputation group at the time of the study had undergone an average of 1.15 surgery, that's 20, and required a new prosthesis during growth approximately every 15 months. The limb salvage patients had undergone an average of 3.5 surgery. This is an interim study. None of the patients were skeletally mature, and the limb salvage reconstruction groups are expected to require further lengthening procedures in the future. So reevaluating this group at maturity, which is ongoing at the moment, is key. So we hope that when we complete this assessment of our amputee and stage reconstruction patients at maturity, and I might have to change my mind yet again when we discover those results. Just a little bit of a sidebar. As you've already heard, we've referred to foot ray deficiency as being lateral and congenital fibular deficiency. And I said this myself in our publication in 2001. It's also been alluded to, a review of fibular deficiency patients at Scottish Rite. And I constructed this table, which included, for all the different associated anomalies, absent lateral rays. And it made sense. It made sense from what I'd read. It made sense from what I taught. There was this anterolateral acetabular deficiency, plus or minus a lateral femoral neck deficiency. As we've already heard, a lateral condylar hyperplasia, producing both patellar instability, external rotation, and valgus deformity. And of course, the stereotypical hypoplastic lateral lower leg compartment. So it made sense, lateral, lateral, lateral. That article had been published about 15 minutes when Dr. David Hutnick told me that the rays in the fibular deficiency were central, not lateral. And he had turned out to be the lead author of that favorite article that I'd read back in 1981 and pointed out that with his colleagues, he had identified that the midline metatarsal dysplasia and fibular deficiency was indeed central. So we took a look at the patients from our patient population with fibular deficiency who had x-rays of their foot that we could analyze. And we found that 21 feet in 20 patients had a reduced number of rays and a clearly developed cuboid or calcaneal-cuboid correlation, which we took a surrogate for the lateral ray. and only 2 feet in one syndromic patient had a truly deficient lateral ray. So in the vast majority, at least, the ray deficiency is central. And ironically, the person who is credited with the first English publication of fibular deficiency, Wagstaff, in 1873, reported 3 cases, including the dissection of 1. All had 3 toes, and he concluded, I did not feel that there's enough evidence to allow one to determine which toes are absent, but in the dissected one, the 2nd and 4th appeared to be so, because there was no medial cuneiform, while there was a cuboid remnant and perineal tendons presence. So it says, it ain't what you don't know that gets you in trouble. It's what you know for sure that just ain't so, which is attributed to Mark Twain. The other thing that I would like to point out is that my goals and expectations may not be the same as my patient and their families. This is not a patient with fibular deficiency. He's a patient who has with a tibial fibular diastasis, the Jones type 4, a Weber type 2, or Paley type 3A, congenital tibial deficiency, at the age of 7 with a 4 centimeter limb length inequality and a rigid 80-degree equinovarus deformity. An amputation had been refused, so the plan was to wait for the development of a distal tibial-ossific nucleus, then perform a soft tissue release and gradual ankle distraction in an external fixator, and follow that with acute correction of the equinus deformity and ankle, meaning a distal tibial epiphyseal talar arthrodesis, and acute mid-tibia varus deformity correction. What does frame look like at the end of the correction? What does x-rays look like 1 year later? And later on yet, we've achieved our tibial epiphyseal talar fusion while preserving the distal tibial epiphysis. And down the line, he has a residual 3.5 centimeter discrepancy. He had declined any further surgical correction on the right side and had a contralateral epiphysedesis. And this is the clinical appearance at maturity. As I mentioned, he declined any second lengthening and had a contralateral distal tibial or proximal tibial and fibular epiphysedesis, and has a residual 3.5 centimeter discrepancy, which he accepted. And this is him walking in our media department. If you look carefully, you can see he has hindfoot equinus, a little bit of rocker to his foot. When he starts to walk to and from, you'll see he has some residual varus as well as the discrepancy. But it would say, I would overall, and I suspect that our colleagues would agree, this is a very good outcome. But despite that very good outcome, when presented with the options, the majority of patients at our institution elect a SIME amputation. And I'll close with a couple of adages that have guided me. One is I've never in my life learned anything from someone who agreed with me, attributed to Dudley Field Malone in the Scopes monkey trial. And also is the reasonable man adapts himself to the world. The unreasonable man persists in trying to adapt the world to himself. And therefore, all progress depends on the unreasonable man, George Bernard Shaw. There are some patients, obviously a throwaway news article, but there are times that we don't get to debate what to do. It's been decided by a higher authority. A child was born with a wooden leg, which obviously was a Streeter's dysplasia, but they thought it was an indication of reincarnation. So we didn't discuss that. So in conclusion, congenital fibular deficiency is a complex condition with a broad spectrum of deformities, and consequently, treatment encompasses a broad spectrum of options. There's no one-size-fits-all strategy. What is unacceptable for one family is the best choice for another. And finally, the treatment options and results continue to evolve. Be prepared for change. Thank you.
That's great. Thanks, John. That was a very befitting last talk in this really lively session. So I know we were a few minutes ahead of time, but I would like to maybe present a couple of conclusion slides and then maybe open up for a brief discussion amongst our group, because I know we've got a lot of talent here. So again, this is just a recap of all the talks we've heard so far, and I'm sure these are going to be archived and it'll be a classic for many, many years to come. So I really thank all the panelists, and of course, SICOT and my co-moderator, FIRAS, SULEIMAN, for having this webinar. So I think these, I would say, is my attempt at summarizing all that I've heard this morning or this afternoon. Fibular hemimelia, and somebody in the panel, actually one of the audience commented that maybe that term itself is a misnomer and it should be, limb dysmorphism. Be that as it may, it is of sorts a post-axial hypoplasia of the entire lower extremity. But just like Dr. Birch said, the foot issues may be more of a central deficiency rather than lateral. The associated limb anomalies, as we heard from Dr. Standard and others, it's the entire extremity starting from the hip and pelvis down to the toes. And so it's very important to clinically and radiographically assess the entire extremity and, of course, the entire patient and their background, their psychosocial needs, resources, etc. And once you meet the family, as we've heard from Dr. Hamdy as well, is you got to make a lifelong plan, including the severity of the limb difference, the psychosocial issues, what does the family and the child want and need, the age at presentation, as was nicely pointed out by Dr. Hosny, and then again, surgeon experience, anecdotal or long-term, and then what does the literature say, even despite its limitations. And then this age-old sort of controversy, lengthening reconstruction versus prosthetic reconstruction, and does one size really fit all? Different choices in different cultures, and I think it's very befitting for this broad audience and broad speaker group to bring in different cultural norms and healthcare delivery systems, and to see how it fits the patient and the caretaker. And finally, this whole controversy on what is a functional foot. Does it depend on the number of rays? Does it depend on ankle mobility, etc.? But I think overall people would agree that the ideal would be to have a quote-unquote functional plantigrade foot with some ankle motion if feasible, but if not, at least a plantigrade foot. And as we heard from Dr. Paley and Dr. Standard, you got to address the ankle joint malorientation, be it with a super ankle, a short, or a mini super ankle. But the concept is you want to reorient the tibiotalar joint and the hind foot as best as you can prior to limb reconstruction with lengthening. And then, as we heard from Dr. Radler, recurrent deformities is an issue. Even if you get the limb realigned, there's going to be issues with recurrence from, let's say, distal femoral valgus, if you've retained the fibular onlog, and if you have a ball and socket ankle. And finally, as again heard from Dr. Hamdy, interdisciplinary team approach, if it can be feasible in your setting, is key. And even if you can't get everybody in that same team at the same time, I think having a good hold of physical therapy and orthotics and some form of psychosocial support is key. And as we mentioned, avoid one-size-fits-all strategy. The techniques, the implants, the outcome measures will continue to evolve. And very befittingly, like Dr. Birch mentioned in his talk, you got to keep an open mind with a willingness to learn and change with time and evidence. And please, for our audience, fill out a post-webinar survey. Here's the QR code, and a reminder that our next SICOT Pioneer webinar is on free flaps, so please register for that. And once again, an invitation to all to join us at SICOT annual meeting in Cairo, Egypt on November 8th, 2023. So with that, I will stop sharing and see if there's any final thoughts or questions or comments.
Could I make a comment? This is Tony Herring.
Yeah, let me welcome Dr. Herring from Texas Scottish Rite. Thank you, Tony. Please.
Thank you for this great seminar. I think you really put it all together beautifully. I want to give just two comments, really. One is the way we approach it. John Birch and I have worked this out over 40 years. We see a new baby at about age 6 weeks, and they go to the reconstruction clinic and see another child with a reconstruction. They go to the amputation prosthetic clinic and see another child with that. We tell the parents, no decisions at this visit. We want you to learn all about it. We bring them back at 6 months of age, and we go through the same things. And one of the things we assure the parents of is it's not their fault. This happened at before 6 weeks of gestation. So something, like automobile accident or a glass of wine at 6 months of age or 6 months of gestation, had nothing to do with it. They don't need to feel at fault. And we find that once they come back at about 9 months of age, they know what they want to do. We also open them up to other patients they can contact. So they're fully informed, and sometimes what they pick surprises us. But we would just tell them, we're not trying to have you do what we want you to do. We have you to be very informed. And people will say, well, people of this ethnicity or this such and such don't favor amputation. But then I ask, well, what ethnicities and social people like amputations and come wanting one? But when they know everything about it, the other factors don't seem to play much. The other sort of simple point I'd like to make is, of our amputee kids that I have that play sports, I've only seen 2 cases out of hundreds that had any symptomatic anterior cruciate problems. Only it seems like they can play football, even though they have an anterior dorsign and some identifiable instability. It doesn't seem to be a functional problem for most of them. So thanks again for the great seminar.
Yeah, thanks, Dr. Herring. Any other panelists want to say anything?
Great.
Yeah, I would agree with. It was a great webinar. I would agree with Dr. Herring that the knee absent ligaments they do need to be reconstructed every so often, but not as much as we think. And I have a lot of patients in high level sports, and they seem to do really well.
Yeah, Shawn, do you think it matters? Like if you're doing a femoral lengthening, perhaps it's more critical to have a stable knee as opposed to below the knee with a tibial lengthening?
I think so. And I think what we've learned now that we've gone into the internal kind of lengthening and we don't bridge joints anymore is really critical just to maintain full knee extension and at least 45 degrees of flexion. But really the full knee extension, losing a little bit of extension, 10 degrees, 15 degrees, really can bite you. I think also looking at a passive, fully extended preoperative x-ray, if you have translation that's already present, then that's, I think, someone who would benefit from a reconstruction.
Thank you. Firas, any final comments, closing thoughts?
No,
your audio was working earlier. Sorry.
What I want to ask about the earliest age we can touch such a case, because I have a kid of one of my orthopedic friends, and he has fibular hemimelia with equinovarus, not valgus, equinovarus, which is a rare entity, and he is pushing me to do surgery, and he's almost at the age of 8 months now. So I don't know if anyone have any experience with early doing super ankle before the age or at the age of 1 year, or we should wait. I don't know. Yeah,
usually 1 year if the child's big enough, you can. I wait for 1 year for pulmonary development for the foot to be big enough. But with the equinovarus, and it seems, we have quite a number of those in our practice, and I don't know why, but they are really tough. I don't know if I have any that have not undergone eventual ankle fusion, which is John Mike, because he does a lot of the casting pre-op, and then he kind of goes. But the ones that I have seen a little bit later, they're usually recurrent deformities, and so I would treat the club foot initially with the casting, and you're trying to create an equinovalgus foot, and then you treat it for fibular hemimelia with whatever technique that works for you. I kind of do the tried and true. With Dr. Hosny, I need to kind of flip my cards. I've been in the game for 20 years, and I've been doing the same thing for 20 years with the classic super ankle, and so I need to kind of look at those. But it's a distal tibial osteotomy plus or minus a subtalar osteotomy with a mid shaft if there's a bow present with an X-fix. And but I would definitely, if the child's foot is small, wait to 18 months, maybe 2 years. If the child's big enough, 1 year can be done. But that the equino varus is the tough one.
Oh. Thank you.
Great. We're a few minutes past our time. So thank you, everybody. And thanks again to SICOT and Sofian for all their help. I think we can end the session now. Thank you.
Thank you very much.
Thank you.
Thank you.